Okay, hello everyone. My name is Jackie Grandy and I'm the Outreach and Education Coordinator for the National Eating Disorder Information Center. Many of you will know me before. If you've tuned into these webinars, I'm lucky enough to be able to curate our webinar series. And we're going to get started. I want to welcome everyone to the room, everyone who's here. If you are having issues with audio, with the quality of the sound, with the picture, do let us know. And though there's not much we can do if you're having issues now, we are very happy to make a copy of the webinar recording and the slides available to you after the live webinar today. So look for those in about a week. And I'll go ahead and introduce Alma now. So Alma Naddafi is a colleague of mine. She works just down the hall from us at Fertility. Alma is a nurse practitioner here at the Eating Disorder Program at Toronto General Hospital, and she works with both the inpatient and outpatient programs here. Alma has a varied nursing experience, and that includes national and international nursing practice and nursing leadership and education roles. She's committed to comprehensive quality patient care and patient education, and Alma's academic achievements include a Master of Arts in Adult Education from Central Michigan University and a Postmaster's Acute Care Nurse Practitioner Diploma from the University of Toronto. So today Alma is going to be focusing on eating disorders and fertility issues, which are such common concerns for clients dealing with eating disorder concerns, and certainly it's an issue that many of us can relate to. So I'm happy to welcome Alma.
Thank you so much. It's always nice to get a beautiful and very comprehensive introduction at USD, so thank you for that. I also want to thank Nedic for inviting me to do this talk, and more importantly, I want to thank all of you who took an hour of your busy day to actually come and learn and share something with us about menstruation, infertility, fertility, and pregnancy. I should mention that as we are going through the presentation, feel free to actually either ask the questions, and Jackie will be monitoring some of the questions posed, and we will do that at the end of the presentation. I believe we will answer some of the questions that have been posted. Okay, so why don't we get started? So first of all, I thought that to address the issue of potential fertility, infertility, I thought that we may go very briefly and discuss what a normal menstrual cycle looks like. Now, preteen, when we are just in the pre-adolescence stage and we are just reaching puberty, there is a rhythm of nerve impulses generated between the hypothalamus that actually release releases pulse-like activity that in turn releases the gonadotropic releasing hormone. Again, this process controls the release of luteinizing hormone and the follicle stimulating hormone from the pituitary gland. Again, all this one in the brain. And there is a timely onset of normal menstrual function. Again, this is whether it is the initial menstruation or subsequent menstruations, this process will develop pretty much the same way. And when the onset of normal menstrual function happens, that's when the young woman or the woman will actually start getting their period. At the end of it, the cycle will start. The menstruation will stop, and the cycle will start all over again. And again, this process continues through our life until we, as females, enter menopause or become menopause. So this is the normal menstrual cycle for everyone, regardless of the existence of eating disorders or not. So now let's look at what happens during eating disorders and the menstrual cycle. As many of you know, anorexia nervosa and bulimia nervosa are very complex medical disorders. And I have made my presentation more specific to AN and BN because that's where we have most of the evidence in regards to fertility, infertility, and pregnancy. But I'm more than happy to entertain any other questions that you may have. So again, focusing on AN, we know that there is a marked weight loss resulting in amenorrhea. And again, in the medical literature, amenorrhea is classified as missing at least 3 consecutive menstrual cycles. And this one, we believe it is what we call a secondary amenorrhea, where there is a hypothalamic pituitary dysfunction, where there is a decreased conversion of hormones by the fat mass, leading to low circulating levels of pituitary gonadotropins. So again, this all happens at a hormonal level. So moving along, the characteristic of hypothalamic amenorrhea syndrome is, again, when the cessation of menstruation happens. And what we know during this period of time is that there is a reduction of hypothalamic gonadotropic releasing hormone, which is signaling to the pituitary gland, resulting in failure of ovulation. So now we not only have a lack of menstruation, but also a lack of ovulation. Again, I should clarify that this may or may not be the truth for every patient, meaning that some patients may still be ovulating in the absence of menstruation, and or they may have the absence of menstruation and absence of ovulation concurrently. Again, the degree to the impairments of these two naturally occurring episodes, whether it is menstruation or ovulation, varies from patient to patient. In general, there is a frequency and amplitude of the luteinizing hormone and follicle-stimulating hormone pulses, which may be diminished. And when all this cycle is happening in the presence of eating disorders, there is evidence that there is a reversion to a prepubertal pattern in the development of amenorrhea, meaning that women specifically go to a prepubertal state. There is some evidence, and many of you probably have read some of this evidence, that when this happens, and there has been evidence that the uterus has actually decreased in size, and that also that the ovaries have gone to prepubertal state. I hope I'm not going too fast with this, and if you find that it's going too fast, please let us know. So in terms of functional amenorrhea, we know for a fact that this is a temporary, reversible disturbance of hypothalamic pituitary function. So again, just the process, the cycle that I started my presentation with has been totally disrupted or interrupted. There is amenorrhea seen in AN and BN, and usually we will see that of a secondary type, unless you work in the pediatric sector, where you may actually see young kids that never really get menarche. And that will be classified as primary amenorrhea, meaning that they never had an onset of menses. So the literature is not very abundant when it comes to fertility, infertility in patients with eating disorders. However, we have a little bit more evidence when it comes to AN and amenorrhea. And what we know is that 20 to 25% of patients experience amenorrhea before the onset of significant weight loss. And in fact, there is evidence that many of these patients may end up going to have an initial visit with their healthcare providers because they are more concerned about having lost their menstruation rather than losing the weight. We also know that in some patients, 50 to 75% of them will experience amenorrhea during dieting and its weight loss. So as they are actually either engaged on various diets and they are progressively losing the weight, we will see that the amenorrhea happens in about up to 75% of them. In bulimia nervosa, we know for a fact that there are menstrual irregularities, and that they are much more common than amenorrhea. What you will see is that women with bulimia nervosa may actually menstruate fairly irregular. And by that I mean, I have patients that will tell me that they will menstruate once every 3 months, and then 3 months later, they will be menstruating twice a month. And so, again, really a lot of education is really important with these patients. That's not to say that amenorrhea doesn't happen in this patient population, but it tends to be a little bit less frequent than with patients with AN. I thought that it might be interesting for us to talk very briefly about the DSM-5 and really to look back at where we were before the DSM-5. As many of you probably remember, the DSM-4 requires some criteria, or criterion D, where it specified the amenorrhea, or the absence of at least 3 menstrual cycles, had been deleted, and that was inclusion criteria for determining AN. Again, there were problems with that, as you can imagine, that we couldn't apply these criteria to males, young girls, and females taking oral contraceptives, because we really didn't know where their menstruation or their menstruation pattern will be like. And also we had difficulty with this criterion because we couldn't apply it to postmenopausal females. The other issue is that in some cases individuals exhibit all other signs and symptoms of AN but still report some menstrual activity. And I know that some of you may have concerns about that, and I'll be happy to discuss some of those concerns. So there has been quite a bit of literature search in the last decade regarding amenorrhea and BMI. There are various studies that are non-conclusive. For example, this study actually talks about the critical relationship between BMI, body fat, percentage of body weight loss, and the occurrence of amenorrhea. Again, trying to establish variables, if you will, to try to figure out why this happens. Other studies point out to the fact that maybe we have an adaptive hormonal response to things like whether amenorrhea is due to an adaptive hormonal response or things externally like excessive exercise. And there has been some evidence that elite athletes actually experience amenorrhea. And also we know that chronic nutritional energy deficiency, whether there are vitamin deficiencies, also can contribute to amenorrhea. It's good clinical practice in any young woman that may be experiencing amenorrhea to do TSH, or thyroid function test, to actually rule out any hypothyroidism. So we are going to move gears. Right now we are going to talk about infertility and what is some of the evidence we have for patients with eating disorders. So female infertility, and I'm going to talk about this one in general terms, and then I'll make it specific to patients with eating disorders. So in the general population, we will actually determine the diagnosis of infertility when we have evidence that a couple have had unprotected intercourse for 1 year, or after 6 months when the female is greater than 35 years of age. We also will look for potential causes of infertility. So we will look at history of menstrual cycles, what's their pattern like, and in the community you will also want to explore what's the family history like? What was their mothers like, their grandmothers? So that's good information to gather from our patients. And again, this applies to patients with eating disorders and patients with no eating disorders. We also want to get a history of STI. So did they have any sexually transmitted infections that may have contributed to infertility? Any type of surgery, but mainly we are focusing here on any gynecological surgery or even abdominal. It's also good practice to do a good physical exam, and that will include the weight, the BMI, a pelvic exam, and what we are looking here is again for STI and for endometriosis. We will evaluate for tubular occlusion and other abnormalities. Again, these abnormalities can be seen through either an ultrasound or laparoscopy. And again, these tests will be ordered based on the history. For example, a history of STI or irregular menstrual cycles may prompt us to look at structural abnormalities. Another test that is pretty easy to do is really to confirm ovulation. Are they ovulating? So mid-luteal progesterone levels we will do and basal body temperature charting. So we can actually suggest these things to our patients. And the clinical pearl is that we always evaluate ovarian reserve in women greater than 35 years of age. Again, because the evidence tells us that there is a decrease in reserves in females above the age of 35. So now, if we apply our knowledge to female infertility in the presence or in the context of eating disorders, what we know is that approximately 5 to 10% of women seen in infertility clinics are found to have covert AN or BN. So these are not the patients that we as clinicians are aware that they already have an eating disorder. This is the rest of the population. Also, the presence of an active eating disorder is commonly felt to be a contraindication for pregnancy and infertility treatments. Now, as you can imagine, if 5 to 10% of the women seeking infertility treatment go with without disclosing their eating disorders to the clinicians, this can be pretty problematic. Now, there is some disagreement with this percentage. There is some evidence that the general population makes similar percentage of women actually going to fertility clinics. So again, this is opposite opinions, but the concern overall is that that these women with the active eating disorders should not be subject to infertility treatments. We know that, and I think this is right here, we know that these patients may actually come to the clinic and request, and at times there is some case studies that will say demand some medications to facilitate conception. We have currently little evidence regarding what are the consequences or the side effects of fertility drugs in patients with AN more specifically, and more generally with eating disorders. We know that the induction of pregnancy by methods such as pulsatile luteinizing hormone release hormone or LHRH is not medically or psychologically advisable. Again, for various factors. We know that pregnancy poses a stress on the physiological stress on the system, and if these women are already dealing with an eating disorder, that can be an added stressor. There are also reported multiple pregnancies due to the drugs that we use, and these may even be more difficult for patients with AN than for women without ED. In the general population, actually, that may be considered a side effect of multiple pregnancies. So as you can imagine, with patients with AN, it is another stressor and additional concern that we need to have as clinicians. I want to talk about the therapeutic interventions, but I also want us to be fully aware that these therapeutic interventions are ideally used in patients with no eating disorders and patients in the general population. And if we were to use some of these therapeutic interventions for patients with eating disorders, it's advisable that they are fully recovered from an eating disorders. And the evidence points out to the fact that ideally it should be 1 year post-recovery from an eating disorders. And post-recovery is defined as the ending of treatment or unsuccessful treatment of an eating disorder. So meaning the patients that are at a normal BMI and have maintained that weight and that BMI for at least a year before we start considering any therapeutic interventions. So again, very general therapeutic interventions. We can consider intrauterine insemination for couples with mild semen abnormalities or cervical problems. So that is an option. We can also refer patients with endometriosis and infertility, again, like what I mentioned, to have laparoscopic surgery and or IVF concurrently. And IVF stands for in vitro fertilization. We need also to consider the risks and benefits of IVF. Immediate IVF is severe male factor infertility or severe tubal disease. It might be actually the best therapeutic course. And IVF in older women using donated eggs is probably one of the best options for people that are experiencing infertility. Now, of course, these prevention strategies, again, are for the general population and also for our patients' population. And what we will do as clinicians is to encourage pregnancy before age 35. We know, and there is evidence, that the likelihood of pregnancy with each IVF cycle decreases with advancing maternal age. And that for all fertility treatments, the chance of success decreases with advancing maternal age. And I'll go into a couple of studies that have been done. And there is that fertility is less related to paternal age. So it's really more related to how old the woman is in this case. We also know that diagnosis and treatment of cervicitis and pelvic inflammatory disease is really important, and it's something that that should be done promptly. We know that PID may cause fallopian tube scarring and obstruction. So again, that needs to be investigated before we even consider any of these treatments, actually. So there has been a few studies done. And more specifically when it comes to, to maternal age. And what we know is that maternal age and fecundity are variables that we need to consider. And the likelihood of live birth decreases 3.5% per year after age 30. And this was a 1991 cohort study which enrolled 751 women from donor insemination center to evaluate the impact of maternal age in fecundity. So pretty large study when you think about some of the scant evidence that we have. There is also evidence that overall live birth rate after 6 cycles of IVF was 72%. And for women under age 35 was 86%, and for women 40 and older, it decreased to 42%. So pretty big numbers. And again, this is a cohort study that was done of 6,164 couples undergoing their first IVF cycle, where they measured the fertility rates and the impact of maternal age. So again, these are statistical studies that we need to discuss with our patients. So we thought that we will do a short section in eating disorders and pregnancy. So before I go actually any further, I want to just take a moment and reflect that, as I mentioned very briefly early on, that ideally we should counsel our patients with eating disorders to entertain pregnancy when they are fully recovered from an eating disorders, and ideally after a year of being able to maintain their normal BMI. So what we know in eating disorders and pregnancy is that women with AN do become pregnant and are more likely to have unplanned pregnancies. And again, this may be that we know that there is a lack of menstruation, or they have amenorrhea, or in some women they may have irregular menstruation, which may lead them to believe that they are infertile. And some of our patients actually, and I see this quite often in my clinic, they may be under the impression that conception is unlikely or even impossible. Some of them believe that they might not be able to conceive, which brings me to a point that I should make, that the evidence actually is not, there is no evidence that women that have recovered from eating disorders have higher incidence of infertility than the general population. So pretty much it's the same percentage for our patients that are fully recovered. Also, another concern with our patients with eating disorders is that we know as clinicians that many of them may be using medications, whether it is whether they are being used as purging methods or using them for other purposes, including other substances or drugs. We know also that women with AN before pregnancy are also more likely to smoke during pregnancy, and we have some numbers, 37.1% compared to 9.2% in women without ED. So a pretty high percentage of our patients with AN will be smoking. And there is also some evidence that they continue to smoke throughout their pregnancy. Now, obviously, this behavior poses some not only fetal but also maternal complications. So we know that women with AN and some patients also with BN may have a higher incidence of premature births, miscarriages, increased risk of hyperemesis, so they will complain of nausea and vomiting more often and probably have more episodes throughout the day than women without eating disorders. We know also that the infants of these women are a significant lower weight than the general population. There is also some evidence that the infants may also have microcephaly. So microcephaly is smaller head circumference. And they also may be small for gestational age. So the progression of weight for these babies is much slower than babies with mothers that don't have an eating disorders. We also know that there are some studies that tells us that approximately 1/3 of women struggling with eating disorders believe that pregnancy could provide a means to recover from their disorder. So they hope, and some of them will be fairly convinced that that getting pregnant may be a solution to the eating disorders, even though they also will tell us that they have this fear of the gestational weight that needs to be gained, and they may believe that the weight gain will be totally out of their control and that they will not be able to manipulate this variable. They also report that they view gestational weight, again, this is other subset of women, that will report that the gestational weight gain in a large body size may be more acceptable during pregnancy than under any other circumstances. And again, some of them that I have seen in my clinic may attribute this one to the societal values of what is an ideal female body shape and weight. However, just like in any other medical field, there is evidence that points to the contrary. So we know that eating disorders relapse during pregnancy is fairly common. Some literature points up to 33% of the relapse rate, and depending what you are reading, some studies may point out a little bit higher or lower percentage. We also know from literature that there is the symptoms may be exacerbated or be fairly active. And again, this is applies to both AN and BN. We also know that there is a higher incidence of a high risk of C-section and postpartum depression in women with eating disorders. So really, when we are dealing with this patient population and their desire to be pregnant, we have to be very cautious. And ideally, there should be quite a bit of counseling before pregnancy, during pregnancy, and post-pregnancy. Not only with the patients, but with their families. And my clinical opinion is that ideally it should be from an interprofessional approach, where we have dietitians, where there is a richness of knowledge that we can share with our patients, and also the support during pregnancy. And again, definitely, if we were to have patients that are having an active eating disorders and pregnant, we need to collaborate between all the healthcare practitioners, and more specifically the psychiatrist and the obstetrician, because if there is need for medications from a psychiatric point of view, we also need to ensure that the obstetrician is aware of this. And again, I think I mentioned this several times, that ideally it will be best practice to actually deal with the eating disorders before pregnancy, and this is if it's possible. The peril here is to actually have this frank discussion with our patients and really make them aware of the risk benefits of conceiving. So moving along, after our patient may have had the baby, there is evidence that some of these women may be unwilling to consume the additional 500 to 600 kilocalories per day to sustain breastfeeding. And in fact, many of them will tell us that they want to provide the rich nutrients that breast milk have, but they can't really sustain the caloric intake that is required for this. They also may stop breastfeeding in order to engage in more extreme weight loss measures, or engaging in extreme weight loss measures could really put in jeopardy their lactation. So either women go back to their symptoms, so as you can imagine, if some of the symptoms were excessive exercise, breastfeeding their infants may actually get in their way of having the time to actually do the exercises. And also, if they do engage in extreme weight loss measures like excessive exercise, breast milk may actually be very scant and eventually cease. So it may not be the most appropriate way to feed the infant. Other women may find that breastfeeding does result in reduction in weight and fat. So some women will tell us that they breastfeed their infants even longer than women without ED because they have a hope that by actually delivering those calories to the baby that they will continue to lose weight. So fairly problematic. And of course, probably some of you know that there are parenting concerns and issues with women that have eating disorders and their parenting skills. I think that could be an interesting topic for a different presentation, but the evidence tells us that many of these women either underfeed their babies or their children, and they are very strict and controlling about what their children ingest. And so parenting concerns that I think it will be worth it to discuss at a later date. Okay, and I think that's my presentation. So I will be happy to entertain any questions or comments that you may have.
Fabulous. Thank you so much, Alma. This is, I mean, this is a topic that just resonates with, I think, anyone working in a medical role with folks with eating disorders, with women with eating disorders in particular. And we actually, I'll give folks some time to type questions in the chat box, but we had quite a few people send in questions with their webinar registration. So I'm going to read out some of these and ask if you're comfortable to address some of them. And this one question really stood out for me. So one individual has asked, for some people with an eating disorder history, pregnancy can be a healing experience, and I think you touched on that. But for others, it can trigger relapse. It can even worsen an eating disorder. Is there, I guess in your clinical experience, is there any way to predict which one of these a woman will experience? In other words, how can a practitioner know whether this will be a potentially healing or destructive experience for women?
Yeah, that's a really good question. The evidence tells us that, like you saw in the previous slide, that, some women will relapse, some women will see that as a healing experience, and we also know that some of them may continue to have body image issues. So I think based on what we know and what the literature tells us, that discussion, not only preconception, but for me, is that I think I'm privileged in the sense that I have access to these women while they are getting treatment for their eating disorders. So I grab the opportunity to actually share some of this knowledge with them. And the answer is we don't know, really. We don't really know who is going to, do well or relapse during pregnancy. What we can do is to actually address some of the issues that they have. So let's say body image issues. How do they envision that, pregnancy may be a healing process or potentially a trigger for relapse? So I think having that frank discussion with them and showing them the statistics and where do they think that they may actually be, it may be a good starting point.
Yeah, that makes a lot of sense. And I imagine you'd also just be having a discussion about the risks and benefits very plainly as well, laying them out as soon as possible.
Absolutely.
We have a question from Julie, a registered dietitian. So Julie's asking, would you suggest a shorter breastfeeding duration, so in other words, maybe 6 months at a maximum, for women who've given birth who have an eating disorder? How would that affect breastfeeding, or would you have any sort of specific advice for those women?
That's a really good question, a tough one, I would say. And the reason for my perception is that the reality tells us that breastfeeding is a personal choice. We have evidence that breastfeeding an infant for at least 6 months prepares them not only with immunity, but also that provides all the vitamins and nutrients that are essential for that infant to develop. I will not suggest actually at a specific time, because I will have to take into consideration, first of all, what is the maternal health. So if a woman is either relapsing or requires some medication that I know may be affecting the infant, then my advice would be to stop breastfeeding. So I guess the answer is I don't really know unless I have that case in front of me with all the information regarding what are their current symptoms, what is the health of the baby, what is their current medication history, what's happening in the family, and in the family dynamics. How are they viewing? How are they bonding with this infant? So there is a lot of variables to consider before I can actually suggest. And but I probably will make a suggestion, and I think Julie is right. I may have to go with a specific amount of time. So I might say, if she's very adamant about breastfeeding, I would say, let's aim for 6 months. Again, depending what is the clinical presentation.
Mm-hmm. Yeah. That makes sense. And regardless, I imagine, Julie, you'd also be wanting to work, if possible, to work closely with a nurse practitioner or doctor or the team that's surrounding that client to see what her unique circumstances
Mm-hmm.
are. There was a question from Melissa who's interested in eating disorder workshops or seminars in the GTA. So I could take that one on, Melissa. Well, here at MEDIC, we do host these webinars every 2 months or so. The best way to find out what's happening in your area would be to give the MEDIC helpline a call. So in this case, you can call our number in the GTA, and the helpline number is 416-340-4156. We can provide you with a listing of events happening locally. And another organization that I would recommend would be the National Initiative for Eating Disorders, or NEED, N-I-E-D. And they host regular symposiums that you'll want to look into as well. We have another question from Vanessa that's come in. So Vanessa's asking, are you aware of any studies that have indicated a short-term increased fertility in low-weight starvation state? So I wonder if that's a question that you feel comfortable answering, or if it would require a little bit more legwork for Vanessa.
I actually don't know of any recent studies. I haven't come across, and I really search the literature quite frequently. But again, it may be yes, that I don't know.
Mm-hmm. That, it sort of ties into another question that we got with the registrations, which is, why do some women continue to menstruate at very low body weights while others do not? So in other words, are there other factors, I guess, that would predict amenorrhea in women of low body weight compared to other women of a similar body weight who aren't dealing with amenorrhea?
So before I answer that question, let me just make something straight. I think in regards to Vanessa's question, I did mention during my presentation that it's medically advisable not to actually undergo any fertility treatment where a patient is experiencing an active eating disorders. And from your question, I gathered that if they are a low weight, and I think your question was if fertility in low weight starvation state, the advice is not to. Now, and there is quite a bit of ethical debate whether it is advisable to provide fertility treatment to someone that is starved. And again, like I said, I don't know of any recent studies, but the general consensus among healthcare practitioners is not to proceed with any fertility treatment. So in regards to your question in amenorrhea, all of us are very different. And I think as a nurse practitioner, I have learned that patients not only respond differently to treatment, but they have different physiological needs. The evidence is very clear, and the literature points to the fact that some women actually never lose their menstruation, even at a very low body weight. So we have, I work with some clinicians here and psychiatrists that have been in the field much longer than I have, and they tell me case reports of women that have been at a BMI of like 11, 10, and still have the menstruation. So the short answer is we don't know why. And we know for a fact that menstruation may actually be posing a bit more stress on the system. Now, let's not forget that many of these women may actually be taking hormone replacement therapy, so they may be on the birth control pill, and that may be forcing menstruation to happen. But again, like I described to my patients in very simple terms, it's artificially induced menstruation. So it's not really naturally occurring, but rather we are making it happen by keeping them on the birth control pill.
Mm-hmm. So that's a very good point. Do you have a few more questions in you?
Why don't you? I know that they have actually asked some questions,
okay.
So I'll let you take the lead on that.
One of the questions that stood out for me, and I wonder if you're able to answer this one, is how do eating disorders in males impact their fertility? So when you're looking at things like sperm count and fertility among males,
mm-hmm.
How do eating disorders affect that?
So, it's really, we know that eating disorders, and more specifically AN, is the incidence is less in the male population. However, we know for a fact that infertility or transient infertility can actually happen in males pretty much the same way that it will happen in females, meaning that what we know in males is that if we were to do a sperm count, we know that they have a significant lower sperm count. And again, it is because, and if we were to test their testosterone levels, we actually find out that they may be lower than normal. So again, it's physiological, it's very similar, but of course different.
Mm-hmm. And thank you. There's been another question that's come in the chat box. So Kat is asking, for someone who's been a long-term vegetarian or vegan, would you suggest attempting to return to a diet that includes animal products for the duration of a pregnancy or for a period of time afterwards if breastfeeding? So what do we know about the interaction between diet and fertility for people who've been living with an eating disorder?
So again, this is a similar question to the previous question that was asked of how long will I advise patients to breastfeed? And there is never an easy answer to this question. So in regards to vegetarian or vegan, those are personal choices. And one of the things that I find that is very helpful with our patients is to actually help them understand the reasons for this chosen lifestyle. So what prompted that? So if the answer is it is an eating disorders type of behavior, or the eating disorder is actually directing this kind of behavior, then probably we need to address that. If it is for ethical and moral issues, then I think as a clinician I have no right but to respect their choices. So my position is that I will work with the patient, and I find that this approach is very, very successful. So my clinical obligation is to ensure that they have all the nutrients, the vitamins and nutrients that are required. So I will be doing blood work that includes things like what the literature tells me. We know that people that are vegetarian and vegan may be deficient, let's say, in iron because they do not eat animal products. They may also be very low in vitamin B12, so I will actually be compelled to do all those tests and treat accordingly. And but like I say, more importantly, to actually help my patients to understand what is the reasons for that lifestyle. And if it is non-related to the eating disorders, then I will support their choices and really do what is required. There is not a lot of evidence in what is the richness of, if you will, of the breast milk, like if there is any difference. Not that I'm aware of anyway, so I will not go into further discussion about breast milk and that kind of variables.
Mm-hmm. Well, I know that from my end, there's two more questions that we can ask if Alma, if you're up for them. And one question that came in is, could you recommend any solutions for hypothalamic amenorrhea? So this would be when menstruation stops as a result of issues with the hypothalamus. So this might be a little bit different.
Mm-hmm. I love this question because the answer will be fairly simple. Let's get to a normal BMI. Let's treat the eating disorders. So the saying food is medicine for these patients is totally accurate. We know that when the hormonal balance is viewed in our physiological system as a luxury, meaning that your cardiac and renal function take priority over hormones. And we know for a fact that once the patient is totally recovered from an eating disorders and at a normal BMI, and they have recovered for about a year, that when we measure any type of hormonal levels, that they will actually be normal. So we have that evidence. So therefore, we will just actually really help them and assist them and support them in their refeeding process.
Mm-hmm. So for folks perhaps on another end of the spectrum, dealing with binge eating during a pregnancy, or even for people that are binge eating, during the whole pregnancy process, what are the effects that we know of? So in other words, what are the short-term or long-term effects of binge eating during pregnancy on the mother or the baby that we know of?
So I think we discussed that, and let me go back to that slide where we talk about the what are some of the effects of that. So really that applies not only to their patients with AN, but also with patients with BN. And I'm trying to find it here where it is. So we know that the babies have a low weight. They may have microcephaly. So right here. So again, the maternal complications are for all patients. So if I will imagine that if it is BN and the woman is let's say purging quite frequently, we know as clinicians that the electrolyte imbalance, mainly the hypokalemia or low potassium, is very detrimental to health. So we also know that in pregnancy there is more cardiac requirements. And if we know that low potassium can affect cardiac function, then as you can imagine, we will be concerned about the patient's cardiac function and what is the oxygenation for this baby. So we will be really concerned. Ideally, these patients should be monitored very closely. And when I say very closely, I'm talking about potentially weekly, along with blood work. So the effects are not only health concerns for the mom, but also for the infant or for the fetus, because they may be developing and gaining weight at a much lower rate than the infants of mothers with no eating disorders. And we know for a fact, and there is evidence that they are small for gestational age. So all those are pretty significant risk factors. I think I mentioned before also that many of these patients will be using medications as a way of purging or assisting with the purging behavior, so that can also be very detrimental for the baby. Again, we need probably a bit more fluids when women are pregnant. And so if there is a dehydration or lack of fluid intake, that can be very, also very detrimental to the fetus.
Well, I think that you've done such an amazing job, Alma, of addressing the material, and it is a lot of material, but giving a really concise overview and tackling quite a few very specific questions that we've gotten both from people here and from people via email. So I really want to thank you. I want to thank you for coming here. It's been such a treat. We will be closing up the webinar now, but for those of you who want to review the material or to watch the full recording of the webinar, we will be getting that out to you next week. So do look for that in your inbox. And I'm sure many of you wish that you could talk to Alma about many of your cases and your clients and perhaps friends and family members that are struggling. Feel free to email me, and we can try to pass on questions and comments as they come. And I also want to give you the number once more for the NEDIC helpline, which is another good resource if you're looking for information. So if you're in Toronto with Alma and I, the number to call is 416-340-4156. If you're calling from elsewhere in Canada or from outside of Canada, the number is 1-866-633-4220 or 1-866-NEDIC20. One more question that's come in. Let's see if we can get to it. So what are the effects for a client who restricts during the day but binges or eats more than normal amounts in the evening? Is there anything that you would add to that, Alma?
So I think what is hormonal imbalance happens whether you have AN or BN. We have evidence that in terms of menstruation in the menstrual cycle, it will affect pretty much slightly similar but different. And by that I mean that in AN we will see amenorrhea, and BN we will see menstrual irregularities. What the effect will have really regarding binge eating and more normal amounts in the evenings, I don't know if we have done any studies with people exactly in that kind of variables. What I will know is that definitely they will have an effect, because metabolically they are not actually staying at the optimal physiological level that is meant to be. And by that I mean, ideally a human being should adhere to 3 meals per day and snacks in between. So if that is not happening, then physiologically your body doesn't understand that behavior. So immediately you may actually resort to think, is this a natural disaster? Is there scarcity of food? So really physiologically it tried to adjust, and decreasing some of the hormonal levels is a way of actually compensating.
Well, thank you so much, Alma. If any more questions do come up, send them to us by email or phone, and we'll try to answer them as best as we can. And between Alma and myself, hopefully we can address the questions as they come up. Thank you for creating such a lively discussion with us today and for joining us. Thank you so much, Alma.
Thank you.
It's been just a treasure to have you here, and I want to thank everyone else again and wish you all a wonderful week.
Thank you so much, everyone. Pleasure to share some of my knowledge with all of you.
Thank you, everyone, and please consider joining us next time.